Very good morning to all of you. Today, the topic of discussion is the mandibular major connectors. Major connectors are a key component of the removable partial denture prosthesis or the cast partial denture. A major connector is defined as the part of the partial removable dental prosthesis that joins the components on one side of the arch to those on the opposite side. That is, a major connector is a key component which will join all the parts of the cast partial denture on the left side to those on the right side. And the major connector can be classified as maxillary major connector and mandibular major connector. Today, we are going to be looking at mandibular major connectors. In this lecture, you will learn what are the requirements, the general requirements and the special requirements of mandibular major connectors, the different types of major connectors, their indications, advantages, and disadvantages. Taking a look at the general requirements, which is common for both maxillary as well as the mandibular major connectors. All major connectors must be rigid. Major connector is the main component. It is the main part which connects all the other parts of the cast partial denture. It provides support to the cast partial denture prosthesis. So the major connector must be very rigid. But it should not impinge the free gingival margin. Always the major connector is kept away from the free gingival margin. The border of the major connector should always run parallel to the gingival margin. And there should be provision for placing denture bases and artificial teeth where required. This major connector should be self-cleansing. It should not cause any food impaction. And it should maintain patient comfort. I told you it must be rigid, but it should not be bulky. It should not interfere with the speech, the phonation, and the mastication of the patient. It should not cause any interferences to the tongue. There are some special requirements which are particularly needed for the mandibular major connector. The mandibular major connector is placed 3 millimeters away from the free gingival margin. I told you the border of the major connector should not coincide with the free gingiva. It should be away from the free gingiva. For mandibular major connectors, it is placed 3 millimeters away from the free gingival margin. All mandibular major connectors must be rigid, but they should not be bulky. They should not interfere with tongue movements. They should not interfere with speech and with mastication. For mandibular major connectors, relief must always be provided, especially if it is a distal extension case, that is Kennedy's class 1 and class 2 cases, relief must always be provided. We have to be very careful where we place the lower border of the mandibular major connector, because you all know the lingual vestibule is not very deep. It is quite shallow in most cases, and the major connector must not impinge on the tissues of the floor of the mouth. How do we measure how much space is available for the major connector? A very simple way of doing it is ask the patient to protrude the tongue to touch the vermilion border of the upper lip. Then we take a probe, a Williams probe, and we measure the distance from the floor of the mouth to the free gingival margin. So this tells you how much space is available for placing the major connector. So that is, we ask the patient to protrude the tongue. Then we take a Williams probe, measure the distance from the floor of the mouth to the free gingival margin. You all know the mandibular major connector must be kept 3 millimeters away from the free gingival margin. If you measure the total space available from the free gingival margin to the floor of the mouth, minus 3 millimeters from it, this is the space available for the mandibular major connector. Now, the lingual bar, the first type of mandibular major connector is the lingual bar. This is the most commonly used mandibular major connector. Now, while designing your cast partial denture, your mandibular cast partial denture, the major connector we use should always be lingual bar first. We first think of a lingual bar. Only if the lingual bar cannot be given do we look at the other designs of mandibular major connector. It is not like this for the maxilla. For the maxilla, each edentulous case has its own requirements. But in the mandible, we always think of the lingual bar first. Only if the lingual bar cannot be given due to certain reasons, only then we look at the other mandibular major connectors. The lingual bar has a half pear shaped cross section. The superior border is kept 3 millimeters away from the gingival margin. The lingual bar must be at least 5 millimeters in width. The width of this lingual bar must be a minimum of 5 millimeters. And it is kept 3 millimeters away from the free gingival margin. This means that the total vestibular depth that we require should be 8 millimeters. We need 8 millimeter of vertical space between the free gingival margin and the floor of the mouth. Only then can we incorporate a lingual bar major connector. When we look at the indications, like I told you before, it is used in every Kennedy's classification. This is the first one that you will think of. Only if the lingual bar cannot be used, only then you will think of the other ones. And looking at the advantages, it's very simple. It is very easy to design, easy to fabricate. It has minimal contact with oral tissues. It does not have any contact with the teeth. So no caries formation or decalcification of teeth is happening with this. Little bit of food entrapment and patient discomfort will happen if this is placed over an undercut. Okay, it cannot be used when mandibular tori are present. And suppose the vestibular depth is insufficient, then there are chances of making this very thin and very flexible. That is why you always keep in mind that the minimum width for the lingual bar should be 5 millimeters. The minimum vestibular depth required is 8 millimeters for placing a lingual bar. So what happens when we don't get these 8 millimeter of vestibular depth? We can go for another modification of the lingual bar, which is called the sublingual bar. It is kidney shaped in cross section. It can be placed deeper in the lingual sulcus. When sufficient vestibular depth is not available, we go for a sublingual bar. Okay, this is an example of your sublingual bar. Or another option is giving a lingual plate. When sufficient vestibular depth for giving a lingual bar is not available, the next design that we think of is a lingual plate. Here, the lingual bar extends in the superior direction up to the cingulum portion of the teeth. In the first picture, you can see the wax pattern for the lingual plate. You have the pear-shaped lingual bar inferiorly, and superiorly, the plate becomes thin and it extends up to the cingulum of the teeth. It covers the cingulum of the anterior teeth. Okay, so it looks like a thin, solid plate of metal. The superior border is scalloped. It should follow the outline and the curvature of the teeth. And it should have knife edge margins. There should not be any wedging effect on the teeth. It should not cause any food impaction in those areas. Okay, it merges. If you see the second picture, you can see how the superior border uniformly becomes thinner and merges with the lingual surface of the lower anterior teeth. And the anterior lingual plate on both sides, it is always supported by a rest on the mesial fossa of the first premolar. This also provides indirect retention. Okay, so this is a compulsory fact. The lingual plate should not extend beyond the first premolar. It should be supported by a rest on the mesial fossa of the first premolar. Now, if there is spacing between the teeth, you see, look at the second picture, you will see there is spacing between the lower anteriors. In this case, if you give a lingual plate, then what happens is when the patient smiles, the metal is seen through, which looks quite anesthetic. So in this case, we use a special design called the cut back design of the lingual plate. Now, what are the indications for the lingual plate? When the lingual frenum is very high, like when I told you the vestibular depth is less than 8 millimeters. In those cases, we go for a lingual plate. And then when there is excessive ridge resorption in Kennedy's class 1 or even in Kennedy's class 2 cases, with excessive ridge resorption, the height will be very less, vestibular depth is very less, and then we cannot go for a lingual bar. So we give a lingual plate. Then for stabilizing periodontally weak teeth, if the lower anteriors are mobile, when we give a lingual plate, in future, suppose a tooth is lost also, we can just solder a loop and add an additional tooth. So that is one main advantage of the lingual plate. It stabilizes the periodontally weak teeth. It also gives provision for addition of artificial teeth in the future. One main advantage is it is very rigid. It provides good support and good stabilization. And because of the rest given on the mesial fossa of the premolars, it also provides indirect retention. And it's more comfortable to the patient, and the phonetics is also better. But there is extensive coverage of teeth that may cause decalcification and subsequent caries formation. And because there is excessive amount of soft tissues also covered, soft tissue irritation is also a possibility. But still, when the lingual bar cannot be given, this is a very good option for most cases. The next major connector that we are going to look at is our double lingual bar, which is also called the Kennedy's bar or continuous bar retainer. It looks similar to a lingual plate, but the central portion has been removed and is hollow. Okay, there is a superior bar is there, an inferior bar which looks like the lingual bar is there, but the middle portion has been cut out and removed. That is your double lingual bar or Kennedy's bar. If you see the wax pattern, you will get a better idea of the design of the Kennedy's bar. The lower border, okay, the lower bar looks very much like our lingual bar. It has a half pear shaped cross section. The upper bar is half oval in cross section. It is 2 to 3 millimeters high and 1 millimeter thick, 2 to 3 millimeters in width and 1 millimeter in thickness. And the central portion, the metal has been, the wax has been cut out so that the central portion is hollow. And in cases of diastema, we gave a cutback design in the lingual plate. Similarly, cutback design can also be given in this double lingual bar or Kennedy's bar. And again, the two bars are joined by mesial rest placed on the mesial fossa of the first premolars. These rests also provide indirect retention. The indications for this double lingual bar are when you don't want, there is the periodontally the teeth are weak, you want a lingual plate, but you don't want excessive coverage of metal. And there is periodontal disease. There are embrasure spaces are there. Wide diastemas in lower anteriors. In all these cases, you can go for a double lingual bar. Because of the mesial rest provided in the first premolars, these provide very good indirect retention. They stabilize periodontally weak teeth. They also have an open area in the center, which can be easily cleaned and maintained. The gingival tissue in the open area receives good stimulation. These are a few of the advantages of the Kennedy's bar. But looking at the disadvantages, there are two bars running, one superiorly and one inferiorly, which causes a lot of interference and annoyance to the tongue. The patient always complains of multiple borders being present. Chances of food entrapment are pretty high, and these are very difficult to fabricate. Chances of the superior bar breakage are also pretty high. The next option is the labial bar major connector. This is the fifth type of major connector, mandibular major connector, that we are going to be looking at now. The labial bar major connector. It is a very cumbersome major connector. It looks like a lingual bar, but the bar is placed on the labial vestibule, which itself says that it is going to be very uncomfortable to the patient. It is given only when the lower anterior teeth are so lingually inclined or tilted, or lingually there are some bony deformities that a lingual bar or a lingual plate cannot be given. This is done only when you cannot give a major connector in the lingual aspect. Okay, usually done in surgical cases only. Okay, this is again half pear in shape. It is, the cross section is similar to the lingual bar, but it runs across the labial or the buccal mucosa. And the height, the thickness, and the length is more than the lingual bar. Okay, it runs across the facial surface of the mandibular arch, and it is given when the lower anterior teeth are malposed, severely crowded, lingually inclined, or there are severe and abrupt tissue or bony undercuts on the lingual aspect, or large inoperable mandibular tori, or due to some surgical defects, you cannot give any major connector on the lingual aspect of the mandible. Only then you go for this. The advantage, there are no specific advantage. It is used when there is no other choice. Okay, usually in surgical cases, after cancer surgery, rehab, etc. Okay, this is the only advantage, is that when we cannot give it lingually, you have an option to give it labially. That I can say that can be only the single advantage of this major connector. Disadvantages, it is highly aesthetic. You have a thick bar running on the labial sulcus, which is very unesthetic. It distorts the lower lip. In patients wearing this prosthesis, the lower lip always looks like it is everted, and it is very uncomfortable to the patient. So like I told you before, this is done only when there is no other option. There is a modification of this labial bar, which is called the swing lock prosthesis. Okay, it is again done when the lower teeth are severely lingually inclined, and after maybe some surgical cases, after cancer surgery, rehab, etc. The labial bar has a hinged joint on one side, like a gate, and this gate can be opened and closed. The gate is opened, the labial bar is moved out, the gate is opened fully. You see the second picture, you can see how the gate is opened. The appliance is placed inside the mouth. Then the labial bar is swung shut and it is locked in place with a small lock in the appliance. This kind of appliance is called a swing lock appliance. Like I said before, it is cumbersome. It is difficult for the patient to wear. It is difficult to fabricate. It is very bulky, interferes with speech. It interferes with aesthetics, phonation, etc. And this is done only when there is no other option. So this brings us to an end of this lecture. Before we leave, let us take a quick recap of the mandibular major connectors. There are 5 mandibular major connectors: the lingual bar, the lingual plate, the sublingual bar, the Kennedy's bar or the double lingual bar, and the labial bar. All mandibular major connectors must be rigid. They should not be bulky. All mandibular major connectors are placed 3 millimeters away from the free gingival margin. There is always a provision given for attaching denture bases and artificial teeth. The first one you see in the picture is our lingual bar mandibular major connector. The lingual bar mandibular major connector must have a width of at least 8 millimeters. It is kept 3 millimeters away from the free gingival margin. So the vestibular depth required is 8 millimeters. The lingual bar major connector is always the major connector of choice. It is done in most cases only when we cannot give a lingual bar major connector, maybe because of insufficient vestibular depth, or because of inoperable tori's do we think of other mandibular major connectors. The lower picture that you see is a double lingual bar or a Kennedy's bar mandibular major connector. It has two bars, one superiorly and one inferiorly. The inferior bar looks like your lingual bar, and the superior bar is thin, 2 to 3 millimeters wide and scalloped and must merge with the teeth. The central portion is open for better hygiene maintenance. When the lingual bar cannot be given, the other option that we have is a sublingual bar, which is placed deeper inside the lingual sulcus. Now, the next mandibular major connector that we are going to look at is the lingual plate. Again, when the depth for a lingual bar is insufficient, we go for a lingual plate, which extends up to the cingulum of the teeth. And it is a thin plate-like extension of the superior border of the lingual bar. It can also be given when the teeth are periodontally weak. And if there is spacing between the teeth, a step-back design can be done. The last one is your labial bar, where it looks like a lingual bar, but it is thicker, wider, and it is placed in the labial sulcus. This is done when the the lower teeth are tilted lingually and a lingual bar or a lingual plate cannot be placed. So these are the 5 mandibular major connectors. Okay, this tabular column is given in your textbook. It gives a brief outline of the types of the mandibular major connectors, their shape, advantages, disadvantages, indications, and contraindications. It becomes very easy for you to learn. This, along with the diagrams, will suffice for your exams. Thank you very much.